Okay, we are live.
Welcome to the debate of the use of restraints and seclusions for people with autism and other developmental disabilities. This will be conducted as a formal debate. My name is Christina and I am the attacker on the con side. I would like to introduce the other members of the debate. For the pro side, we have Taryn as a stater and prover.
Hi.
And Molly as the attacker.
Hello, hello.
For the con side, we have Amanda as the prover.
Hi.
And Anna as a stater.
Hello.
So to go ahead and just jump right into it, seclusion and restraint is also known as the term S&R. It's really a controversial topic, and it always has been. The use of physically affecting another individual at first thought really seems like it's unnecessary, it's too much. In a lot of situations, it is unnecessary. However, there are times when an individual will cause meaningful harm to themselves. They'll honestly hurt another innocent individual, or they will cause severe property damage. In these situations, allowing a person or persons to be harmed so severely when you are able to appropriately block them from such harm is a blatant disregard for the individual's humanity and the respect for them as a person. So to kind of break down these two topics a little better, restraint is when a person is physically hindered or blocked from having free range to implement damage. The individual must have prior consent for such action, and any individual adaptations reviewed by other individuals for the respect of them, so that their individual self is held at their highest value. This is really important for BCBA specifically because one of the codes in the Code of Ethics, number 4.02, talks about involving clients in the planning and the consent of their own treatment, as well as families in the consent and planning of their child's treatment. So when trained individuals meet these needs and the person having a behavior is given the opportunity to take their own time to calm themselves down while unable to injure themselves or anyone else, this is really positive for them. Seclusion is a similar method, but with a slightly different application. So it involves a lot less physical presence, and for some individuals, that physical presence is not an option for them, and they still potentially will need intervention. So the intervention they provide in these types of situations is to a removal of a less stimulating area until they have reached a level of rational calm and they are able to make better options, better decisions. The same rules apply as in restraint, where they must receive prior consent from not only the individual but their family and those implementing the treatment, and have individual adaptations applied if necessary. These are both de-escalation techniques, and while they're definitely a last resort method, they also have different levels of intensity within their own categories as well. So for example, in a situation where there is likely to be harm, but the individual is not fully escalated, a less intrusive block is able to be provided to match the behavior that is occurring. So it's a more effective intervention to prevent harm while still providing that ability for them to self-calm without injure themselves or others. Blocking typically takes the shape through of a variety of methods. There are several, such as PCM, CALM, HWC, PART, and CPI. All of these methods have their own regulations, but they all agree on a lot of several points. The several points include recognizing triggers of behavior and warning signs for escalating behavior, so as to prevent any blocking procedures that don't necessarily need to occur. So implementing good therapy and positive therapy with informed individuals can take away a lot of the situations that would have ended up in a hold or a restraint or a seclusion situation. They also really emphasize and teach to recognize signs of distress, generally holds or situations that potentially have the possibility of causing harm to the individual involve multiple individuals who are implementing the strategy, and these people are all trained to recognize the distress through these systems. So these systems are very clear on how they do it. Professionals teach them, and because there are multiple people involved in these situations, there are multiple people to be on the lookout and be aware. So yes, there is human error, but the general majority of people will be able to avoid that type of situation, or if there's any distress starting to occur, we'll be able to rectify it immediately. Like I said earlier, it is a last resort method for intervention, and it is to be used as infrequently as possible and only as a very last resort. When it is used, it does need to be documented. There is a quote that says, in the event that crisis planning and de-escalation efforts fail and SNR is used as a life safety measure of last resort to manage an extreme behavior emergency, then SNR techniques and methods should be reviewed in advance with a parent or guardian and consent obtained. So this means that the individual needs to have all the documentation in order prior to it occurring, as well as when it does occur, it needs to be documented. So it's not word of mouth or guesses, that this is a very clear and serious thing that is taken as such. It is also really important and not often mentioned that all of these systems teach how to establish and reestablish strong and supportive relationships with these individuals after each occurrence. Due to the potential for psychological effects, it is very important and is taught by the professionals how to counteract this immediately so that the individuals still feel like they have that accurate of the support that they have from the individuals, and that it doesn't leave lasting effects on them. And if it does show adverse effects that implications, then steps can be taken for that. So overall, what would the field of service look like without the appropriate use of SNR? It would be very different. Individuals who fall into the category of requiring SNR would be discriminated against. They would be banned from services. When they are in services, it would be random decisions that are made by unprofessionals with no proper experience or training. And while they may be very well intended, severe harm and death easily come from those who have no real knowledge, especially when they're frustrated and upset and stressed out by a situation where they have no tools for a solution. Fewer individuals are going to go into the field. People in the field are less likely to be happy due to the fact that the supporting hierarchy of individuals in this field will be destroyed in a sense. The individualization for individuals as well as the support team will have less tools to provide for those working one-on-one, leaving them defenseless and without an appropriate means to solve situations other than to really just call 911 and wait for them to arrive. However, 911 providers are not adequately trained for this type of situation, so further harm is likely to occur, as well as the dignity and respect of the individual client at the time will not be honored, which is a very important thing, as to do the Code of Ethics 2.05 talks about the rights and the prerogatives of the client and how their rights are paramount and need to take full consideration in everything that we do. So it is unethical to provide therapy when a situation can be predicted to arise where their rights and their prerogatives will be diminished. Another point to mention is what happens to these individuals when they are no longer able to come to clinics due to these services or due to these problems in services, is that they're going to stay at home and they're going to be cared for solely by their parents who have less training, less knowledge, and have more free range of action that they can take. So what is going to happen to these people who get left behind and ignored? SNR is really actually a very necessary tool that is needed in order to help those who are in need. It's not necessarily therapy within and of itself, but it is the only way to provide therapy to those who really desperately need it. And there are many, many individuals out there like this. To cover the con side of the debate, there will be Anna.
Hi, thank you, Molly. We can say all these things to justify why we should use restraints. I think we should not use restraints and seclusion to individuals with developmental disabilities, as it is not right in any way. These procedures, they may violate human rights. They do not work for students or staff members. There are obligations to the application of restraints and seclusions in humans because restraints cause discomfort and limit personal freedom. There are serious risks associated to both staff members who are restraining and to the students who are being restrained or put in seclusions. Till and Spread 2009 stated that there are so many risks that are associated with seclusions and restraints. Seclusion and restraints also result in psychological harm to children. Sometimes they are traumatized, especially those who have a history of trauma or abuse. Imagine if you were once put in such a situation and you go to a school and you come across that too. It will traumatize a kid. Restraints and seclusions do not add any educational value, therapeutic value, nor are they effective. They are dangerous and unjust. There are reports from the National Disability Rights Network that show that students who have undergone restraints and seclusions suffer physical harm, serious injuries, traumatizations, and even they cause death. Restraints and seclusions do not keep people safe, nor ensure physical safety to anyone, neither a student or a staff. In most cases, they do escalate in the end, resulting in physical bodily harm. Imagine you are being restrained. What is going to happen? It's going to be a power struggle between the two. And in the end, what is going to happen? There are going to be people getting injured. What does research say about restraints and seclusions? There's very little evidence of the effectiveness of seclusions as a behavior change strategy, depending on how it is used. Williams, 2007, stated that there's no research and there's very little research on the prevalence and appropriate applications or efficacy of seclusion in school settings. There's no enough evidence to use restraints and seclusion, especially in schools. People can justify that we need to seclude kids who are having behavior problems because they might cause harm to other kids or to themselves. But there is no evidence to show that this is effective to these kids. Peterson and Albrecht indicated that seclusion and restraints are often used without the existence of dangerous behaviors to those that pose risk or injury to the student or others. As a behavior analyst, what are we supposed to do about these restraints and seclusions? A behavior analyst is responsible for making sure all the operations are in the best interest of the clients. Is it important to seclude a kid? Is it important to restrain a kid? It is the responsibility of that behavior analyst to ensure that the behavior interventions for children promote the rights of all children to be treated with dignity. Behavior interventions should emphasize prevention of negative behaviors and at the same time promote or help in creating positive behavioral supports. If a behavior of a student is affecting his or her learning or that of others, the student should receive appropriate education, functional and behavioral assessments that will help to design behavioral intervention plans that incorporate appropriate positive behaviors. Now I'm going to introduce you to Taryn.
Hi. The United States Department of Education, whose primary goal is to foster a safe and healthy learning environment for all children, has created a set of guidelines regarding the use of restraints and seclusions. This includes 15 principles that are stated very clearly. Restraints and seclusions should only be used in crisis situations where an individual's behavior is posing a threat on either themselves, another individual, or they are causing property damage, which does pose a threat on either themselves or other individuals around them. As explained by Molly in the opening statement, restraint and seclusion should be avoided to the greatest extent possible. It is absolutely a last resort. However, if restraints and or seclusions are deemed the appropriate last resort intervention by a qualified professional in a crisis situation, they can help to spare injury and can potentially be life-saving. They can also both help to decrease the risk of property destruction in individuals that do engage in property destructive behavior, and they can reduce environmental hazards. In 2000, Congress passed the Children's Health Act, which includes minimum standards that must be followed in regards to the use of restraints and seclusion. This includes the fact that restraints and seclusions are used as a crisis response intervention only. They cannot be used for discipline or for convenience. And mechanical restraints are absolutely prohibited and not able to be used. The individuals who are working with the clients and students who may be receiving the restraints and seclusions must be properly trained and certified, and children must be continually monitored while they are receiving restraints and seclusion. The Department of Health and Human Services also set state regulations for the training and use of restraints and seclusion, and they do vary by each state, but there are laws put into effect for each individual state. Again, as we had emphasized, it's extremely crucial that professionals working with individuals who have the potential to engage in maladaptive behaviors which result in the use of restraints and seclusion must follow all of these guidelines with integrity. Everybody should be appropriately trained in crisis prevention and de-escalation techniques. Individuals should be able to notice the signs of distress and use de-escalation techniques and strategies to help to resolve a situation before it gets to the point of a crisis. There are things such as a supportive stance, as well as using certain body language and movements to help ease an individual who is starting to go into a situation where they are heading towards a crisis situation. There are also verbal de-escalation techniques, which are all provided in the training for de-escalation training. It's also very important that these individuals have appropriate restraint training, which is usually coupled with the de-escalation training. They should be all staff, whether they work in a school, a clinic, an inpatient facility, should be trained in the appropriate restraint and seclusion training, along with that crisis and de-escalation training. Some of these include the Crisis Prevention Institute, PCM, which is Professional Crisis Management, and Handle with Care. Now, all of these training programs, as I know Molly had stated earlier, focus on the safety of the individuals coming first. They also do all include strategies for prevention of crisis, de-escalation, intervention, and post-intervention, because as was stated earlier, there are specific things that need to be done in a post-intervention to avoid any harmful situation for the individual who does have to be restrained or secluded. It is extremely important that any individual who is working with these individuals with special needs have a complete understanding of a behavior intervention plan or a crisis plan that's been written for them. Behavior intervention plans are written specifically for individuals based on the assessments that have been done, as well as all of the observations and everything that the behavior analyst has completed prior to writing that behavior intervention plan. So it is extremely important that the staff working with these people are well-versed and are very familiar with the specific individual and their behavior intervention plan so that they can follow it with integrity. Along with that, parents by law have to sign off on all of these plans before they are implemented. So it is important that the parents do have knowledge of these plans that are being implemented for their child, which may include restraint and seclusion training strategies. I'm sorry. This relates to the BACB Ethics Code for .03. The individualized behavior change programs. Behavior analysts must tailor behavior change programs to the unique behaviors, environmental variables, assessment results, and goals of each client. This is important just to explain how every behavior intervention plan and every behavior change plan written for an individual is tailored to their specific behaviors and their specific needs. And the results of that and the seclusion and restraints that may be put into place for them would be according to the behaviors that they do engage in, what the behavior analyst finds to be most effective. Any instance of restraint or seclusion must be overseen by an individual other than the person or people who are implementing the intervention. There must be someone timing it. There must be someone overseeing and making sure that everyone is implementing the strategies appropriately. This must also be properly documented, and the parent or caregiver should be notified of the crisis situation immediately after it has de-escalated. This related to this also is the BACB Ethics Code 1.02, which is the boundaries of competence, which states that all behavior analysts must provide services and teach and conduct research only within the boundaries of their competence, which essentially means that based on the experience and the expertise of the behavior analyst, that is how they will create this programming that is put into the place for the individuals, and that's how they will oversee the programming and all the staff working with these individuals who do become restrained or secluded based on their intervention plans. And next will be Amanda, and she is on the con side.
There are many reasons restraints are deemed unethical and should be banned from use. The emotional and physical damage it creates with not only the clients, but also the direct care as well. According to an article that was conducted in 1991, many nurses and other direct personnel reported feeling guilty and mentally stressed each time they placed an individual into a restraint. The use of restraints not only made them feel guilty with valuable time from other clients, and the staff indicated that they were unable to find alternative treatments due to the lack of training. The video included shows not only some of the harsh realities about restraints, but also further promotes some stigmatisms associated with the treatments used in special needs individuals. The video aired in 2012. The video goes on to introduce a 16-year-old boy who was placed in an inappropriate restraint, approved therapeutic hold due to his refusal to play basketball, and it also discusses another boy who was put into a restraint and actually passed from the restraint.
Controversy in American schools. This is a padded room, a photo spreading from Washington State to parents around the country. They are called isolation rooms, and they're used to restrain some children, including autistic ones. ABC's chief investigative correspondent Brian Ross brings us videotape, and we warn you, it's not always easy to watch.
Surveillance video shows high school student Andre McCollins in the lower right of the screen, about to go through what his school calls skin shock therapy for misbehavior. About 60 volts of therapy are national standards for the punishments or restraints used on school children, including those like Andre with behavior disabilities, later tied spread eagle to a restraint board. And what happened at this school outside Boston, an extreme example, was entirely legal.
Someday we're all going to look back and we're going to say, can you believe what we did here?
An ABC News investigation has found that only 17 states have specific laws protecting from harsh treatment and restraints.
There's thousands and thousands of children that have been traumatized, that have been injured.
In Arizona and Washington State, parents are up in arms over padded isolation boxes or cells where students have been left for long stretches. In Kentucky, a mother found her autistic 8-year-old son had been stuck into a duffel bag like this one, specially made to restrain children.
They held me like...
In Pennsylvania, a group of students with behavioral issues described to ABC News how they had been tied up or manhandled at previous schools. Did it hurt?
Yeah, it really did hurt.
11-year-old Jordan described being locked up in one of those isolation boxes.
It's scary. Really scary. Even for the bravest person in the world, it's still really scary.
And even worse, there have been dozens of students being restrained by teachers or staff, often untrained or unaware of safe procedures.
So as I had mentioned earlier, this video goes on later to talk about how another boy was placed in a restraint because he refused to play basketball, and he was a 16-year-old boy, and he was actually injured too. So another thing I wanted to discuss is as BCBAs, we're required to find the least restrictive methods for helping our clients. An article was written by Sandra Barton et al. In 2008, and it indicated a program had a restraint-free environment and was able to maintain that environment for at least 2 years. A nurse who participated in the study indicated that she simply tells new-coming patients, we don't restrain here. She says it sets the expectations from the beginning for the patients as well as the staff. Most staff members indicated their distaste for restraint due to their emotional trauma and physical trauma. One nurse even stated, our mission should always be to be therapeutic with patients. Restraint seems more like a punishment. In this program, they focus on more in-depth training for one-on-one staff. The National Executive Training Institute introduced a training to enrich the understandings about the use of restraints. The program began with a lengthy video of children and adolescents who had died during the use of restraints. The video also indicated the just restraints that each child had been a part of trauma theory, or rather the idea that those who experience psychological trauma are either sick or deficit in moral character to the point in which they are injured or in need of healing. These trainings also included more in-depth explanations on what to expect from clients, as well as interventions that have been successful in the past and how to execute such interventions. It also needs to be mentioned that the program started out only attempting to reduce restrictions and ended up creating a restraint-free program in the end. It's also important, study also indicated a reduction in the use of sedative hypnotic medication to control behaviors. By the end of the study, staff had become very inexperienced in the use of proper restraints, and it was no longer deemed necessary to use them. There's still very limited evidence to suggest the full effectiveness of the use of restraints. However, this study showed effectiveness in properly training staff and using preemptive techniques to reduce and even eliminate. With so many staff members indicating that they do not have the proper trainings to create a restraint-free environment, I believe it is our job to help them in obtain that training. As per Ethic Code 2.09 Treatment Intervention Efficacy, it is our obligation to ensure that our clients are getting the most effective treatment possible. This study indicates that it is possible to have a restraint-free environment, or at least close to one, with proper training. Next up is with the pro-attacker side.
So one thing that is really vital to keep in mind that when individuals are implementing a procedure inappropriately and they are not following the required criteria, that the outcomes reflect that, and it is not an accurate reflection on the thing itself. So for example, a comparison's sake would be in a medical situation. In that situation, the doctor is the expert in medicine and in the person's health. And when they're prescribing the medication, they provide a very specific instruction. So this is the same as when a professional who is intimately aware of the procedure and the individual communally deciding to put in place an SNR procedure. So if the medical situation, if the patient ignores the rules provided by the doctor and takes the medication in their own unprofessional manner, very extreme consequences can occur, such as death, such as disfigurement, illnesses, things can develop from there. This is also mirrored in an SNR situation. When individuals incorrectly implement SNR, as stated earlier, either with or without proper planning, approval, consent, serious repercussions may occur, such as death, injury, illness, lots of things can occur. In the medical situation, people know better than to think that the fault lies with the doctor. They understand that the doctor is the expert in the situation, and when individuals implement it incorrectly, that is on the individuals who implemented it incorrectly, basically on their head. That was their decision to make. Due to a lot of media coverage over concepts of this, especially covering individuals and school corporations who are incorrectly implementing, many of which are saying things which are very clearly stating that they are not implementing them correctly, videos where you can watch them being implemented incorrectly, it's skewed the understanding of people in the public understanding about it. So they are now thinking that that is correct implementation, and it's terrible and it's leading to all of these terrible things. However, it's the same as the doctor situation. If the person is implementing it incorrectly, then the practice itself is not actually a reflection on the SNR, it's on the person or the organization that is incorrectly implementing them, taking themselves out of their area of expertise and acting on it. So that's something that's really, really important to understand. The vice principal, or president, apologies, the PCMA is Merrill Winston, and he actually said that there is a commonly held belief that teachers, therapists, etc., are using the use of restraint as a form of punishment. And unfortunately, there are people, bad people in the world who do not use restraint improperly. And restraints have in the past been used inadequately, used in malice, and used in ways that hurt children. And it will happen again. There's humans out there, and that is reality. But however, most of these people are not bad people. And that's really important to remember, that the same way when an airplane crashes, it's the only one you hear about. You don't hear about the thousands of successful flights. The same way with SNR. You only hear about the worst case scenarios, the ones where something went wrong, where somebody did something they weren't supposed to do, where something was overlooked and it shouldn't have been, where there was documentation falling through. That's what the media is hearing about. That's what we hear mostly about. However, it's not an accurate representation of what is actually happening, what is actually supposed to be occurring. Under the ethical code for BCBAs 4.08, considerations regarding punishment procedures, it's the behavior analyst's job to ensure that averse procedures are accompanied by an increased level in training, supervision, and oversight. Behavior analysts must evaluate the effectiveness of aversive procedures in a timely manner, modify the behavior change program if it's ineffective. And behavior analysts always must include a plan to discontinue the use of an aversive procedure when it's no longer needed. So it's it's the job of the BCBA to adequately understand and implement these appropriately so that it is an accurate representation of what it is. It's also important to distinguish when SNR is needed and when it might appear that it is needed, but it is not. So kind of back to that situation where it is a last resort, it is really important for people to understand when it is an actual last resort, because it's used in a lot of situations where it was inadequately used. It was used too soon, or it was used in a situation where it wouldn't have needed to be used at all. A lot of the times the distinction lies between the two terms tantrum and meltdown. And the biggest difference between the two is either the presence or the lack of a rational sense at the time. So if a child or an individual is tantruming, they are rational, they are just very emotional. And if a person is rational, then they are able to work through something, they're able to self-regulate, to self-modulate, and those skills can be honed, they can be worked with, they can be taught. However, if somebody's having a meltdown and their rational sense is gone, there is no more getting through to them until they have calmed themselves down to a degree. That is more when these situations, when SNR is required, because harm is occurring and there is not going to be a rational sense left until they have calmed down. And this provides the opportunity for them to calm down to that point. And once they hit that point of calmness, they may not be happy. You know, the whatever upset them is still there. However, they are rational enough that they don't require that extra assistance, and it can just be worked through as a situation then. And it is also, again, just kind of to say it one more time, it's really important to consider what kind of care is going to be available for those individuals who have this kind of severe behavior if SNR was not in place. So as discussed earlier, these individuals are going to get ignored. They're going to get waylaid. They are not going to be able to provide or to be able to receive services. People will not provide them for them. But the people aren't going to go anywhere. They're just going to be home with their families. And the families are going to be intimately aware of what this does to that individual's life. Their quality of life will no longer be as high as it could have been if they'd received accurate services. And that will therefore affect their family members and those who end up taking care of them for their life. And it will turn around at some point, and someone will be able to speak up for these individuals in the same sense that special ed in itself has had individuals speak up for the children who can't do it themselves when they've been wronged. So Christina will now address the con side of the attack.
So let me ask you, would you want to walk into your daughter's classroom only to see her strapped in a chair, restraining her from any type of movement? Do you think that's an appropriate method for your daughter to stop hitting the teacher? Restraints can cause physical and emotional harm and even death. The National Disabilities Rights Network documented incidents from all 50 states where students with disabilities were being abusively pinned to the floor, handcuffed, locked in closets, and even subjected to other traumatizing acts of violence. In fact, in Atlanta, a 13-year-old boy hanged himself with a rope while being locked in a secluded room for several hours. In Wisconsin, a 7-year-old girl died after being held for hours in a restraint by multiple staff. To say the experience is traumatizing is an understatement. A 4-year-old girl from West Virginia was diagnosed with post-traumatic stress disorder after being strapped into a chair with leather restraints. These are just a few examples of what can result from the use of restraints. Studies have shown that the use of physical restraints can cause an increase in psychological harm to children who have experienced prior abuse by other adults. Students with autism or ADHD are most likely to be secluded or restrained, even when they are not physically abusive. Students are forced into seclusion may suffer more psychological harm, such as feelings of anger, boredom, embarrassment, loneliness, depression, just to name a few. While the intention behind the use of restraints is to prevent the child from physically harming him or herself, the outcome is an increase in psychological harm. It is the exact opposite effect. Children with disabilities are being victimized. In addition to being both physically and psychologically damaging, there's little evidence demonstrating the efficacy of restraints. There might be an argument for the use of restraints in a highly controlled environment, like you were saying, Molly, like a hospital with trained medical professionals. But in a classroom environment, their use is detrimental, as the majority of teachers and staff members are implementing restraint procedures are not properly trained, while medical, psychiatric, and law agencies have strict guidelines for using restraints. The educational field does not require such guidelines. Of the 50 states, only 17 require school staff members to receive some type of training. As a behavior analyst, our main goal is to teach new, appropriate, adaptive behaviors using non-harmful reinforcers whenever possible. What does restraining the student teach them? Ethical Code 4.10, Avoiding Harmful Reinforcers, states, the behavior analyst minimizes the use of items as potential reinforcers that may be harmful to the long-term effect of the client. Code 4.09, Least Restrictive Procedure, states we must always use the least restrictive procedures. Pinning a child to the floor is not a least restrictive appropriate behavior. Lastly, Ethical Code 2.09, Treatment Intervention Efficacy, states clients have the right to effective treatment based on evidence-based research. This right is violated when restraints are used in an abusive manner with untrained, overworked school staff members. Next, Taryn can explain the pro side.
The safety of all individuals is most important in any setting, whether it be a clinic, a school, or residential setting. It is pertinent that the appropriate preventative methods are used to avoid a crisis situation that involves restraint or seclusion. However, if a situation does require either, they can help prevent injury and potentially save lives when implemented correctly by properly trained professionals. Each state has different training requirements, so it's very important that the individuals are trained and maintain their proper certifications according to their state's laws. As a behavior analyst, it's important that we put an individual's health and safety first. In situations where these individuals engage in severely aggressive, self-injurious, or destructive behavior, sometimes the least restrictive interventions are not successful. Through assessment, observation, data collection, direct implementation of these least restrictive interventions during crisis situations, behavior analysts use their professional expertise to create safe and ethical behavior intervention plans. This cannot be stressed enough that these are only to be used in crisis situations when de-escalation techniques and other less restrictive interventions have been unsuccessful in neutralizing the situation. However, they are all tailored to the individual and when done correctly are the most appropriate means of de-escalating the situation when other techniques are not effective. The BACB Ethics Code 4.08, considerations regarding punishment procedures, states that behavior analysts recommend reinforcement rather than punishment whenever possible, which we absolutely do agree with. And before implementing punishment-based procedures, behavior analysts ensure the appropriate steps have been taken to implement these reinforcement-based procedures, unless the severity or dangerousness of the behavior necessitates immediate use of aversive procedures, which is what we have explained, that it is an absolute last resort, and from a behavior analyst expertise that they have determined that all of the other de-escalation techniques have not been effective, and that is the reason why appropriate restraint and seclusions are needed. The importance of the right to use the restraints and seclusions in all of these settings is critical, as it allows individuals to engage in these self-injurious, aggressive, and destructive behaviors. The opportunity for adequate placement, as Molly has explained earlier. We have, as we have emphasized, the use of restraints and seclusion should only be used in crisis situations and implemented with fidelity. However, without them, staff would have a lot more of a difficult time managing these individuals who do engage in these behaviors. It is unethical and unsafe for them to be untrained or act just on their instinct when there are crisis situations, rather than having this training. The proper use of these restraints and seclusions in these settings allow the population of individuals with special needs whom have these behaviors, such as aggression, self-injury, and severe destructive behaviors, to participate in educational programs, as they would likely not be accepted into otherwise. And lastly, here is Anna on the con side.
Thank you, Taryn. We all saw the video presented. Do we need this in our classes? Would you want that to happen to your child? Seclusion and restraints have no educational value. They are not effective for any behavioral programs. They should not be used, as they do not solve any problems or behaviors. In fact, they lead to a power struggle between staff and the student being restrained, which in end results in injuries. There is no evidence that shows restraining a student or putting them in seclusion provides educational or any benefit to a student or any component of a student's individualized education plan. If restraints and seclusions are used, it shows the current intervention being used for that student is not working or is not effective. Therefore, they should be modified. For best practice, restraints and seclusion should be the last resort used after everything else has been tried and has been proven not to work. If a restraint and seclusion end up being used, it has to be done following the proper procedure. Code 408, the role of a behavior analyst is to recommend reinforcement rather than punishment whenever possible. Behavior analysts always include reinforcement procedures for alternative behavior in the behavior change program. Behavior analysts ensure that appropriate steps are taken to implement reinforcement-based procedures unless the severity or dangerousness of the behavior necessitates immediate use of aversive procedures. Behavior analysts review and appraise the restiveness of procedures and always recommend the least restrictive procedures likely to be effective. Think about that video. Do you really want that in the classrooms? Now I represent to you Christine.
So I just wanted to thank everyone for participating and hope everyone enjoyed our debate. A question that commonly comes up is, how does one weigh that potential for restraint to prevent harm to the individual engaging in unsafe behavior towards themselves and those around them against the potential for harm as a result of restraint, physical or otherwise? And how might one set guidelines to help staff determine the cost benefit in situations in the moment. Molly, you want to take a shot at it?
I can try. So we did talk about this, and this was kind of a tricky question. We decided that primarily this is a very individual basis. So it'll be a combination of that community team, so it'll be the BCBA, a PCE, the therapists themselves if necessary, the client themselves, their family, all coordinating together. And it's really especially important for that BCBA to follow their own moral code, and just as importantly, if not more so, the ethical code stands, that the BCBA is founded by. And by following all of that, making adaptations for that individual to make sure that that situation is safe. Making a preset guideline is really difficult just because each individual has its own culture, its own language, its own nuances to it. And due to these differences, as well as each individual's specific manifestation of their disability and their age, it's really difficult to make a specific guideline that wouldn't end up being to the detriment of someone. So just making sure that everyone has individually reviewed and is informed of all parts that are relevant to the situation in order to just make the best possible case so that no harm is done and the best opportunity for that individual is provided for them. So, and with that, we will say goodbye.